So depression's common in primary care. This is a slide from the Magpie study done in Wellington and published in 2003. But what it shows is that actually it's younger people who have most of the depression, not older people, contrary to what a lot of people think. For men it's 22.6 in the 18 to 24 range. For women 33.9. Men tend to have more substance abuse problems than women. Overall they have very similar mental health issues. But note that it's much lower in older people, 2.1% in men and 4.8% in women. So how does depression present in primary care? Well, it presents with somatic symptoms in 45 to 95% of pains. And we've all seen this patient who comes in with a headache, fatigue, or backache or neck pain. Very, very common. Of these, 11% will deny there's a psychological issue, so that's quite tricky to deal with. So we have to bridge the gap from physical to mental. And you need to remember that the quality of life of people who are depressed is equivalent to that of somebody on renal dialysis. So they're going to be feeling very sick. And it's no wonder people ask for more investigations rather than accepting a diagnosis of depression. So in terms of bridging the physical to the mental consultation, we need to raise the possibility. Now this can be stressful for both doctor and patient, and very occasionally patients complain. You're saying it's all in my head, doctor. And I think in these situations, for example, the patient who comes in with chronic fatigue, we need to say that we need to check the physical side of this and also the mental and social side of things to be thorough. And I think that's an important word to say to patients. We can do a PHQ-9 check, and if they score a high score on that, I find that patients tend to own the diagnosis much more. And then we need to normalize the fact that having a stressful time is completely normal, that it happens to virtually everybody, and that the patient is not unique in that sense. So why do clinicians avoid a diagnosis of depression? Well, this is from research again based in Wellington, published in 2005. A lot of clinicians are worried about Pandora's box. The irony here is that at the bottom of Pandora's box is hope. So we shouldn't be afraid of Pandora's box. There's the issue of stigma, and that's a real issue. And I tend to use the diagnosis of being stuck now rather than be depressed or anxious. That's what's called a transdiagnostic term. There may be issues of clinician energy and morale. There's the issue of insurance labeling. And if a patient comes in age 22 having had a relationship breakdown and is in tears and upset, and you put a diagnosis of depression, they may go for insurance for a mortgage when they're 32, and the diagnosis of depression will come back up and cost them more money, when in fact you may not have been able to absolutely secure a diagnosis of depression back then. And my own experience is it's very hard to sort out depression from anxiety, from distress. Some clinicians don't like mental health. Many of us who are doctors have been trained to do the physical first, but the problem with going down a physical path without raising the issue of psychological or social issues is that when you come to a dead end on the physical thing, then you've got a bigger problem to do the translation into a mental health issue, and then feeling unskilled in raising mental health issues. In terms of making a diagnosis of depression or distress, the two screening questions for depression are a very good rule out. So have you felt depressed, down or hopeless for all or most of the past month? Or have you lost interest and pleasure in all or most activities over the past month? If they say no to both those, then they're almost certainly not depressed. So it's a very good rule out. A bit like a BNP for heart failure, a negative test is a good rule out. These are, you'll recognize these as the sort of like the first two questions of the PHQ-9. So if the patient answers yes to one of those two questions, then they could be a false positive. So here then you have to do a PHQ-9, or you may prefer to do a Kessler or a HADS, a Hospital Anxiety and Depression Scale, or a Beck Depression Inventory, a BDI. Just remember there's a payment for the BDI of $5. If the patient scores 12 or more, then you need to offer active treatment. Now that does not mean the patient is depressed, and does not mean you start with medication at that point. And we would do a non-drug treatment first unless the context differs, taking into account their past history and previous treatment responses. This is a slide from our own work of 2,642 patients where we did a PHQ-9 questionnaire, and the levels of the PHQ-9 are down the left-hand column: mild, moderate to severe, and severe. And then we did a computerized gold standard questionnaire which gave us a dichotomous diagnosis of depression or not depressed. In the second column from the left, there's those with a depression, and the third column are those not depressed, and then the risk of being depressed given that score. So you can see if you go to the severe column, 20 to 27, there are 37 patients who had a severe depression. That was 1.4%. But there were 10 patients there who were not depressed. So fewer, but you could still not be depressed and have a very high score. If you go down to the mild row there, 156 people not depressed and depressed, and 402 not depressed. So you could still have a major depression even though your PHQ-9 was in the 5 to 9 range. So a high PHQ-9 does not equal depression, but I think a high score generally means distress. Although I do find if somebody ticks all the right-hand column and gets a score of 27, those patients tend to have personality issues, and they're trying to show how distressed they are. Certainly they're distressed, but depression may not be their problem. It may be more their personality issue. So what's the value of a diagnosis in primary care? Well, in primary care, they virtually always overlap. I do a PHQ-9 and a G87 on most of my mental health patients, and they've always got elevated scores. There's a move towards a common mental disorder diagnosis of mixed anxiety and depression, and this will be coming out in the next ICD, the International Classification of Diseases classification. And as I said before, I use the acceptance and commitment therapy transdiagnostic label of stuck, and patients really like this because when they're depressed or anxious, they often are feeling stuck. What's the value of a diagnosis? Well, the treatments are essentially the same for anxiety and depression, the same psychological therapies and the same pharmacological therapies, and I would like to suggest that we spend less time on diagnosis and more time on getting therapy going, because we've got limited time in primary care and many of these patients will not come back for a second visit. So if we don't get something going straight away, then we're leaving the patients in the lurch.
Of disorders that can include either provocation or at least worsening of depression is very long indeed, but I'd highlight conditions that impair mobility, any sort of enduring painful condition. Endocrinopathies, of course, are famous for this, as are a number of malignancies. So really treating the whole patient is an absolute priority here, and a reminder of how important this is comes from the observation that these so-called secondary depressions are much less likely to respond to the straightforward psychological or pharmacological treatments that Bruce and I will be discussing this evening. So if there is an underlying condition, attending to that is really of the utmost importance. We all, of course, wish to relieve depressive symptoms. That is only one of the goals, however, and that's because people's lives aren't just ruled by their symptoms. They're also very much related to how well they perform their social and occupational roles. So we always keep an eye on that. and really emphasize keeping people as socially and occupationally effective as possible. It's sometimes quite a struggle, but usually preventing the loss of a job or a relationship is a lot easier than recovering that after it has been lost. So we put great stock on that priority. And then finally, the prevention of future episodes comes in, and I think Bruce and I will both be speaking later about how this can be achieved both with the psychosocial treatments to be mentioned, as well as pharmacology. And finally, I guess the key thing in all of this is because people vary so much, we really need to take into account their own particular preferences, their abilities to cope with stress, which vary hugely, and also what they actually tend to prefer in terms of what's going to be acceptable to them. Emphasizing this point is also the fact that adherence to prescribed treatment, both psychological and pharmacological, is, shall we say, not perfect, and the issue of treatment failure being related to non-compliance a very real concern for many. Also, I think it's important to recognize that it's not just a question of choosing pharmacology or a psychosocial intervention. The available evidence, which isn't extensive, is nonetheless strongly suggestive that for many, the combination approach is the most effective. A very common example is when someone actually needs psychological input, but is too depressed or distressed to engage effectively, and their initial treatment with medication can sometimes usefully enable people to engage with the psychosocial treatments that are really going to become the mainstay for them in getting well and staying well. So let's get on to the question of antidepressants, which is really the choice that we make when someone crosses a certain threshold in their mind and in the clinician's mind. Whether to go for drug therapy is a significant decision, and I wanted to just take a couple of moments to consider where this interesting term comes from. It's really a very misleading term and reflects a historical accident, because it was the first indication for which this rather heterogeneous group of drugs was found to be useful. However, as mentioned earlier, depression and anxiety have a very fuzzy boundary, so it won't surprise you perhaps at all that antidepressants are very efficacious, possibly more efficacious in anxiety disorders than they are in depression. It's quite surprising to some people until one realizes that these are syndromes that so often coexist in people. The other thing to emphasize there is that what we used to call anxiolytics are probably much less appropriate and have a lower benefit to harm ratio than do antidepressants in treating the anxiety disorders. So really, antidepressants, I would say, are the mainstay for treating enduring anxiety disorders, despite the linguistic confusion there. Many of them are sedating and useful for treating insomnia and agitation, and there's a variety of other conditions there that you can see for which antidepressants have a useful role. We can come back to discuss some of these other uses for antidepressants later if there's interest in that. Back to Bruce.
Yes, well, like any medication, they have multiple effects, and in some situations, if say it's a man with premature ejaculation, then delayed ejaculation is an advantage. If that's not something that somebody's wanting, then that's going to be a disadvantage. So just coming back to this slide here, up to 60% of patients resolve in 1 year. And my experience, I do PHQ-9 scores on pretty well all my patients who I think may have a mood problem. Their scores are lower at the next visit, and that's quite a key thing. So they might be up there in the severe range, but the next time they're down in the mild to moderate range. They've had a discussion of their symptoms with me. They've had a dose of the doctor as the drug, as Michael Barland said in his 1957 book. If you're a nurse, it's a nurse as the drug. If you're a pharmacist, it's the pharmacist as the drug. In other words, the clinician as the drug, the power of the office, if you like. And we will have done some reframing, some normalization, some hope, and some support. And if nothing else, good old biological regression to the mean may be what has happened. If you get a high score today, a high blood pressure today, it's likely to be low tomorrow, just on a regression to the mean situation. In terms of treating depression, NICE, the National Institute of Clinical Excellence in the UK, suggests that for lower levels of severity, non-drug therapies, CBT and computerized CBT. We've got Beating the Blues here, which you can sign your patients up for. If they're not eligible for that, there's moodgym.com, moodgym.com in Australia, Australia National University. That's free. That's been shown to be effective. There's exercise, including yoga and stretching, so any form of exercising. Behavioral activation is absolutely important. One of the things I've realized in my work with mental health is that people shut their lives down when they get stressed, and your job as the clinician is to expand their lives and get them back doing things. And that's the case with everybody who's anxious or depressed. You ask them if they've stopped doing things they used to do, and every one of them will say yes. And there's a simple old problem solving. When people's heads are full of worry and rumination and anxiety, they can't think very clearly. So sometimes as a clinician, you can help somebody, you know, sort out a mess in their life and get them into a pattern. So should we give drugs at the first visit? Now, there was a question that came up that we may want to answer now. Should we give drugs if a patient is suicidal at the first visit? Well, I think most of your patients who are depressed are going to have some suicidal thinking. If you do a PHQ-9, there'll be many of them who tick 1, 2, or 3. And I think that, and I'd be interested to hear David's view on that, that's not necessary indication for prescribing antidepressant. You may be giving them the means by which to end their lives. I mean, that's something to think about. And just remember, the majority of your patients will be in the mild to moderate range, as we showed before. So drug treatment's not first. There are no, by the way, there are no randomized trials of giving an antidepressant the first visit and waiting. Many of those who are severe, and I see patients all the time with severe levels of PHQ-9 who are much better the next week. So I would generally try non-drug first. And according to NICE, they would say moderate to severe depression persisting, or lower level symptoms persisting for perhaps 2 years or so. But obviously, that's a long time to be suffering. Okay, so do drugs work? And it's hard to know whether this slide is the good news or bad news, but this shows you the level of intensity down the left side: mild, moderate, severe, very severe. And then it shows the actual drug effect in the middle column: 6% benefit of drug over placebo in the mild to moderate, 9% in severe, and 25% in the very severe. If you look over in the right-hand column, there's the placebo effect. So in the mild to moderate range, you've got 8 times, if a patient responds to a drug, it's 8 times more likely to be a placebo response. Even when you get down to severe, it's still slightly more likely to be a placebo response. Now, I'm just going to make a comment about that middle column. That is probably an overestimate of benefit, as I'll show you in the next 2 slides. So this is from our systematic review of antidepressants in primary care. This will be a view you're not used to looking at. This is what's called a funnel plot. And this is for this is tricyclics and SSRIs. This is all the studies in our review, all 16 of them. Above the dotted horizontal line are studies greater than 150 people. Below it are the smaller studies with patients with 150. To the right are studies that show antidepressants are effective. To the left are antidepressants not effective. As you see at the cluster of circles at the top of the page there, the big studies all cluster around an effect point, which is the benefit point. To the right, there are 4 little studies showing that antidepressants are effective. If you go over to the left, you notice that there are no small studies with no benefit. And this is a term known as publication bias. So what's happened to the small studies in that light orange circle there? Well, those studies are either ones that the pharmaceutical companies have not allowed to be published because they didn't show any benefit, or a researcher like myself does a small study, finds no benefit. It's very hard to get a small study showing no benefit published. So they end up in my bottom drawer, and I would have a number of studies, sorry, that are small, showing very little or no benefit of anything, and I can't get them published. So this is what we call in the literature publication bias. The next slide is very important. This is from Irving Kirsch, who's a placebo researcher from Harvard, and he was interested in the placebo effects of antidepressants. And to get around this issue of publication bias, he got all the studies from the FDA and put them into this review. And on the left-hand side, we're looking at improvement. On the y-axis, we've got improvement. On the x-axis, we've got severity measured by the research instrument, the Hamilton Depression Rating Scale. As you can see there, the drug line is the dark red line and the placebo line is the dotted line. Until you get up to moderate levels of severity, there's no benefit. Placebo is as good as drug. The drugs don't start getting better than placebo until you get up to about 24 on the bottom line there. And as you get up to the very severe cases, there becomes a bigger and bigger difference. Interestingly, the placebo rate actually drops in the more severe group, and I often attribute to that as those depressions are probably, there's more a chemical effect going on, whereas you get down to the lower levels of depression, it's more a social network effect there. So this is quite important. Now, this study has been challenged by people, but I think the important thing is that there's no publication bias in that study. 50% of trials are unpublished. That's just the unfortunate world of being a researcher. So that's a reality. Whether for good reasons or sinister reasons, there's a lot of unpublished literature. So it makes it very hard to get a true handle on what's going on with these sort of research things. So what are the harms of drugs? Well, I think if you give them too soon, you medicalize the patient. We've got patients in our clinic who are very medicalized, given antidepressants from other people. The placebo effect is 8 to 3 times greater. And you will have seen this, the patient credits the drug, not themselves. Very powerful behavioral act, putting a small pill in your mouth that's going to make you feel better. And you've seen patients feeling better the next day. Well, that's probably not an antidepressant effect. That's probably just their outlook on life. There's the risk of adverse effects and interactions, and there's the risks of overdose. And I actually had this situation some years ago when I was working in Canada of prescribing a tricyclic antidepressant, because that's all we had in those days, to a patient in the late afternoon. I got called to the little local hospital we ran the next morning, and my patient had swallowed my pills. I had to put the stomach tube down her stomach, which is how we got rid of them in those days, and we pumped her stomach and got the pills out. And I asked her afterwards, I said, well, you weren't suicidal the night before because I asked you. And she said, no, I wasn't, but my husband beat me up last night and I decided life wasn't worth living. So I tell this story because I don't think many clinicians have had that experience of having to pick up the pieces. And I had literally given her the lethal means to kill herself. Fortunately, she didn't kill herself. So we had a question earlier about suicidal patients. You have to think about the benefits and harms. Perhaps if they're that suicidal, hospitalization is better than you giving them a life-threatening pill that they can take home. There's an issue about increase in suicidality in younger people. And then there's the issue of difficulty in stopping. Withdrawal symptoms are very common with the SSRIs, not necessarily the full-blown serotonin syndrome. So when do the drugs work? Well, at the severe end of depression from Kirsch's work, perhaps when people have got the more melancholic symptoms, the loss of appetite, the feeling better later in the day. One way of telling this would be a patient with a persisting high PHQ-9. So that's where I find the PHQ-9 quite useful. If a patient stays up in the over 15 range, then I'm likely to think about antidepressants. Patient not getting better even if they're at lower scores. Previous episodes is tricky, of course, because I see patients all the time, I'm sure, have had placebo responses, but of course you can't tell. There may be a family history pointing to it. And just remember, 12% of Kiwis are on antidepressants. By my calculations, probably only 3% of them are getting a chemical benefit. The rest are probably not getting any benefit. And we have loads of patients in our clinic who are on their antidepressants and they're still depressed. You know, that occurs all over New Zealand. So when to follow up? Well, there's no trial evidence on this. The adverse effects, including the serious ones, tend to appear quickly. And there's a lovely quote here from Kay McCall. She's a British GP who suffered from depression. She says, "See us frequently at first. A week is a long time in a Dali landscape. 3 weeks are almost unimaginable." So I think seeing people gives them hope. And I met a GP recently in Palmerston North who actually phones up her patients in the intervening week, which I think is great. And I'm going to talk about the value of telephone calls. Right, so Dave.
Right. Okay, well, this seems like a good opportunity to move on to the range of nasty things that patients can experience when we expose them to these agents. And you mentioned the older tricyclics, Bruce. I'm pleased to say that they're still around and still useful. I think most people now prescribe them for things other than depression, but their usefulness in severe and especially melancholic depression is perhaps undervalued in New Zealand. There are plenty of studies to indicate that at that end of the range, tricyclics have a more robust statistical effect than some of the newer drugs. And I ran across a study from 12 years ago or so, published from an Auckland researcher who, with a similar name to yours, Bruce, who found that the NNT for tricyclics was 4 compared to 6 for the SSRIs. So even way back then, genuine New Zealand data has pointed to the fact that tricyclics are effective. The trouble is that they're trickier to use. They're harder to prescribe because of the side effects and the fact that the dose needs to be titrated, whereas with SSRIs and SNRIs, often much less titration and fiddling is required. The different classes of drugs have different side effect profiles, as you can see there, and I think it's also worth noting that the differences within the tricyclic group are also quite striking. More variability there, particularly with regard to the sedative and anticholinergic effects, which vary a lot between the tricyclics, whereas the SSRIs are really a lot more similar to each other in my experience. So you can see a big range of potential problems there. I think among the problems that are inadequately recognized and managed that would include the activation syndrome and also apathy on the SSRIs. And it's interestingly, the combination of those two, which curiously do coincide sometimes, that may be associated with the increased risk of self-harm that we occasionally see. Let's see if I can move this on. I'm not sure I've got control of this one now. There we go. So apart from the unfortunate side effect profiles, I think it's also true that we've been rather sold a bill of goods from some of the pharmaceutical companies, and a few of the particularly unpleasant adverse reactions have been rather, shall we say, downplayed by the manufacturers. So here we've got one particular example that most of you will have encountered clinically, that of withdrawal symptoms, and as we will discuss, the short half-life agents paroxetine and venlafaxine are notable in this regard, and there's even a severe subgroup who are just simply unable to discontinue those drugs. As mentioned, apathy is an under-recognized problem and may be severe. I like to think of apathy as being something that in small measure can be quite therapeutic in someone who tends to be very anxious or stressed, but it's easy to overshoot, and sometimes people end up rather inactive and inert. This may be confused with a feature of depression when in fact it's a drug side effect. So an important clinical distinction to be made there. Another less common problem that we see in a subgroup is alcohol intolerance. And this becomes very dramatic in a particular group of patients who get markedly intoxicated. The dose response curve, if you like, is shifted way to the left. So one or two drinks might have an effect similar to, say, 5 or 6 drinks before they were exposed to the antidepressant drug. And this gets people into a fair bit of trouble. And some of our own research has highlighted the risks there. I think most patients are warned to avoid alcohol by the package insert and often by the prescriber, but unfortunately it is almost never explained why this is important. It's not because of additive sedation or something like that. It's more because of this really quite pernicious interaction that only affects a subgroup. But boy, when it happens, you can't miss it, and neither can the police, and sometimes the coroner. We've talked a little bit about suicidality. I think certainly its detection is more evident in younger people. It needs to be watched for, and that's another reason why early follow-up is important. I think certainly within a week, the prescriber should at least have telephone contact with the patient to make sure that nothing strange and out of the blue is occurring, because the people who get this reaction of induced suicidality are often very puzzled by it. It includes people who have never been suicidal before. And so it seems to be a true drug effect, but again, thankfully uncommon. Right. If I can move on to the next one, I seem to have lost my...
We just got a couple of questions here. I'll move the slide on, but we had a question about the activation syndrome and what do you mean by apathy or fatigue?
Yes, okay. Well, the activation syndrome is really tends to be a cluster of related symptoms, which can include complaints of insomnia, nervousness. There's visible signs of agitation or even akathisia can appear, particularly with the SSRIs. And it may be surprised to hear that term akathisia when referring to antidepressants, but there's actually a good pharmacological reason for that, and that is that SSRIs in particular amongst the antidepressants are indirect dopamine blockers, which means that they share that effect, although less potently, with the antipsychotic drugs, which are legendary, as you'll know, for producing those movement disorders. So when that occurs with SSRI consumers, it is an important clinical sign and certainly should prompt a review of the prescription, as well as search for other associated problems, which might include subjective distress, insomnia, increased anxiety, and the like. So that complex is referred to as the activation syndrome. Apathy, on the other hand, is, I think, also common, but tends to be less recognized and can be very subtle. And what it really boils down to is a lack of concern about consequences. So people just don't care so much. They don't care, and indeed, that's one of the things that anxious people find to be therapeutic when it occurs in moderate measure. The problem happens when it goes past the range of useful, and people become so apathetic that they don't bother going to work, don't bother fixing the school lunches, don't bother meeting other obligations. And so apathy can be a real worry when it gets to that extent, and people just aren't bothered to do what they need to. And again, this is often confused with depression. I think it can be distinguished, but it's a subtle difference, but an important one. Bruce, I think this is back over to you now.
So what else helps? Well, I've got a slide there on a nurse phone call, 1 to 2 calls a week for the first 2 weeks, decreasing to week 16. Numbers needed to treat are 5 at 6 months. So that's as good as antidepressants for severe end of depression, and better than antidepressants for a mild to moderate depression. We used to have a nurse calling in our clinic. Now we actually have a healthcare assistant. But I think if you're a nurse or doctor and you have a spare moment, then I think a phone call goes a long way. So all these patients are on antidepressants, and the phone call was literally 5 minutes long. Okay, referral to psychiatry. David, this is back to you.
Right. Yes, so I think there's no doubt that the lion's share of depressive and indeed anxious presentations are encountered in primary care. There are so many that don't appear to a clinician at all, that we're really dealing with just that subgroup that do appear for help from the doctor. And again, this is an uncertain but significant group that never make it to a clinician at all. Among those who do come to primary care, I think the great majority are indeed managed there. And what I'd like to focus on now is that relatively smaller subgroup for whom onward referral to mental health services may be appropriate. So I would emphasize, first of all, the ones that are particularly severe and may be unsafe. And some measure of severity can be gauged by the PHQ-9 and other measures, but it's usually pretty obvious to the clinician when somebody is severely ill their functional capacities are greatly compromised. They may be at risk of self-harm. There's also the signal of depression that's severe enough to include psychotic features. Usually these are mood congruent and pretty hard to miss if you spend 10 or 15 minutes with the patient and they talk about their insides rotting or the fact that they are starting to regret everything they've done in their lives, et cetera, et cetera. The other trigger for onward referral might be those patients who, despite all your best efforts, are simply not responding to standard treatment or unable to tolerate it. And there's quite a few patients in that regard. A little later in this presentation, Bruce and I will be covering some of the strategies to address non-response, and many of those can be picked up while still in primary care. Comorbidities with substance abuse are considerable in depressives, and some of that is certainly attempts at self-medication. Likewise, with the anxiety disorders, people often find alcohol or benzos to be helpful in the short term. The problems, of course, with longer term use are well known to this group. And there'll be another bullet there. Yes, some of these, particularly in the older population, are detected in the presence of organic brain syndrome. That might be a traumatic brain injury, that might be stroke, that might be dementia. Whatever it is, if there's clear evidence of organic problems affecting the brain, this is starting to get into the realm of specialist mental health care, and I think a referral at that stage would be certainly worth considering. Okay, Bruce again.
Okay, so we've got to the end of our talk. So our take-home messages are that depression typically in primary care presents with a physical symptom, which makes us makes a challenge for us. We need to consider the underlying causes. Second visit, usually some improvement. Avoid drugs at the first visit. Talk first where possible. Have faith in your skills of talking and just being a warm human being. Remember, there's a big placebo response whenever you use an antidepressant. Use the phone, and this is a point I make to the medical students, that helping patients with depression is very satisfying. There's nothing quite like taking somebody who's very shut down and watching them open up over a period of weeks and months. So we're going to move on to case number 1 now. Do you want to introduce this, David, or would you like me to?
For you to carry on, Bruce.
Okay, so this is actually a patient of mine, woman age 53, PHQ-9 was 16. So if you follow the pathways, technically she's eligible for an antidepressant, but this is the first visit. She was on venlafaxine 75, which she stopped a year ago. And her issue was that her co-workers weren't being replaced as they leave. She felt distressed and undervalued, and she'd stopped seeing her friends and exercising. She hadn't had any talk therapy, and she had no history of bipolar disorder. And I guess an issue here is, should venlafaxine be used first line? I think David and I would agree, no, it shouldn't. It's got a lot of problems with withdrawal, and it is one of the more dangerous ones, an overdose. So, so the things I got her to do was expand her life. I got her to do some more exercise and see her friends. I asked her to, so I talked about green prescriptions, and I chose to talk to her and not prescribe. And down the bottom there, I've got a little thing that I do where I ask patients the likelihood of them doing something. And she said she'd contact her friend Fiona, and I said, how often would that be? And she said 8 out of 10. Okay, well, I said that's probably going to happen. She then said she'd exercise daily, but that was going to be 5 out of 10. So I said to her, in my experience, this isn't going to happen. Can we renegotiate that? and she suggested 3 times a week. That would be likely to occur 8 out of 10. So this was my task list to her that I handed to her on a piece of paper. I get the patient to read it back to me so I can type it into the computer so that it's got that double reinforcing thing. And I saw her a week later. And a week later, her PHQ-9 was 4, so she wasn't depressed anymore. She was seeing friends and exercising. And I think this is the power of the first consultation when you choose to talk. I was the clinician as the drug, if you like. And her PHQ-9 score was lower at the next visit because we'd done reframing, normalization, some hope, some caring. Perhaps she was going to get better anyway. I can't necessarily say I take some credit in that, but she got better and she expanded her life. And I can't underestimate what I think of the value of somebody expanding their life. And David, could I ask you to come in at this point and make a comment?
Sure. I mean, I think it's worth emphasizing that this woman really did have some quite unsettling and demoralizing experiences in her life that probably ushered in this this recurrence of her depressive syndrome. The other thing to say, I guess, in defense of venlafaxine, it is found by many people to be useful and well tolerated. I guess our cautions about using it as a first-line drug are certainly defensible, but it is a widely used agent, and many people have good responses and little, if any, problems with it. I would say, however, that most venlafaxine use is not that different from what you might call an expensive and slightly complicated SSRI. The real difference between venlafaxine and the SSRIs is really only seen at higher doses, like getting above 150 a day. And at that range, the noradrenergic effect starts to kick in, and that probably accounts for a slight efficacy advantage over the SSRIs, but that just isn't evident at usual doses. So it's got a theoretical and occasional practical advantage in SSRI non-responders, but I agree with you that its use as a first line is probably hard to justify unless somebody has clearly needed it in the past and wants it again. Maybe just one more comment.
Back on. Sorry.
Yeah.
Carry on, David.
Yeah, I think it's also the value of normalization, I think, also bears a little bit of emphasis. This is something that we referred to earlier as a principle of providing hope and reassurance to people, because a lot of people in the throes of a depressive syndrome will feel not only isolated but also very much unique in their suffering or circumstances, and particularly those who are having a first episode may not realize just how common in the human condition it is to have these experiences. The other thing about normalization that's perhaps as important is when people present with physical symptoms, which is, as we've seen, very common indeed, realizing or understanding that this is also a common experience, and that many people with what amounts to a depressive illness, in fact, may present with predominantly biological or physical symptoms. And it's hard for people to make that connection often without a bit of help from us. And I think that's also a normalizing process that we're encouraging them to understand, because we've seen people in that situation often enough, and they may not understand at first that it does actually prove to be quite a common usual experience that people with a predominantly physical experience of a depressive illness are also very much subject to improvement with proper treatment.
We've got a question here, David. Great talk, but biggest issue is accessing psychological therapy. I mean, my issue about psychological therapy is have a go at it yourself for a few visits. Hopefully your PHO is providing some psychological services. Our PHO and DHB provide us a significant amount of money to spend extra consultations with patients. So if you're not getting that, you may have to put a bit of pressure on your PHO. But I'd really like to encourage you, my colleagues, nurses, doctors, pharmacists, etc., to have a go and use your humanity and talk to somebody. It's very powerful. You don't have to be the world's best therapist to help people get better. So don't rush for the referral pad. Have a go yourself. 2 or 3 visits, the patient's unloaded to you, and people can feel way, way better. I'm very grateful for just some little bits of input, the occasional phone call. It's pretty simple stuff. And my experience in primary care is that the people David sees are really complicated. The people we see have usually much simpler problems that are amenable to everyday simple psychotherapy. So, David, we'll go on to the next case. Man aged 50, so his PHQ-9 is 16, so similar to the previous woman, but he was promoted at work, but he's struggling. He's a previous episode of depression ×2. He stopped seeing his friends and exercising. You get him, he sees me and I get him exercising and sees his friends, but his PHQ-9 is 19. He's still struggling at work. There's a threat of dismissal. So his depressive symptoms are getting worse. Employment issue, risk of dismissal. So I would be interested in prescribing perhaps to this man, certainly discussing it with him. Would you like to maybe just talk about what the options are? We've got some questions on drugs here. Fluoxetine versus citalopram, one person asked. What are your views on first-line drugs to start?
Well, I think, I mean, the SSRIs, as mentioned, are more alike than they are different. There's certainly some pharmacokinetic differences between them, and fluoxetine mentioned there distinguishes itself by being both very long half-life and also prone to inhibit some of the cytochrome P450 enzymes. So it's certainly a very useful drug, but I guess those concerns when people are being prescribed other medications, the possibility of interactions need to be kept in mind. It's an easier drug to stop, certainly, than the shorter half-life agents. Notably, paroxetine is tricky in that regard, largely because of its much shorter half-life. Paroxetine is also a cytochrome enzyme inhibitor, so it shares that difficulty. So, you know, between the two of those, I would tend to start with fluoxetine. The other options that we've considered are citalopram and S-citalopram. It's isomer, and there I think the main issue is really whether one's worried about QT prolongation. There's perhaps a bit too much said about that in the general population. How much risk there is. Yes, certainly there is a measurable change in QT. How clinically significant it is arguable, and for most people it's benign. However, if one does have cardiac problems, and particularly if there's a history of long QT syndrome, then citalopram is certainly worth avoiding, and probably S-citalopram as well. In that case, sertraline might be a better bet, and sertraline seems to be perhaps the most benign drug from a cardiac standpoint.
It also has other advantages in terms of breastfeeding and pregnancy and things. It seems to be, and it's fully funded in New Zealand. So I think sertraline's got a lot of advantages. It's become my first line drug.
Yeah. The other thing about sertraline, which I think is unusual amongst SSRIs, is it has more of a effective dose range for fine tuning. So, people usually start on 50, quite commonly get up to 100 or 150, and 200 is also not uncommon. So that fourfold range is really pretty unusual, because you'd only get the very occasional patient who goes up to 4 times the starting dose of fluoxetine. I mean, 80, for example, of fluoxetine is uncommon and unpleasant. And that may have been just a quirk of the fact that the starting dose of fluoxetine may have been a little on the generous side. There is some interesting evidence that may be the case, but Lilly was betting on the advantage of 1 dose for one and all, and I think went for 20 for that reason. So we've still got it.
So I got a question here, David. Do we need to do an ECG before commencing, or with either, if you're going to use venlafaxine or citalopram, should you do a ECG? My understanding with citalopram was it's a dose thing, isn't it? It's only a problem when you get up to 40 milligrams a day. I mean, it's.
Yeah,
do you have a view on that?
I think that's. I think that's right, and indeed, that's a very prudent thing to do. I don't think it's really necessary unless you've got some indicators of risk with a personal or family history of cardiac problems. So I think that probably deserves some recognition of the risk, but it's routine ECGs, I would say, would be a bit over the top.
The other issue about doubling the dose, I had a gem on that. There was a review recently. Not much benefit in doubling the dose of antidepressants. I mean, all the guidelines usually say it, but in fact, the evidence base for it, I don't know if you have a view on that, but seems to be pretty small benefit for the. Yeah, you may be better to change to another antidepressant rather than go up a dose.
Indeed, or as we'll come to shortly, augment with a second agent.
Yep. So we've got some drugs there. So do you want to make a comment on that slide there, David?
Well, I think it's pretty much just what we were talking about before. Adding in mirtazapine there in the middle just to put a bit of variety in. Of course, mirtazapine isn't an SSRI or an SNRI like the rest of those drugs there. It really stands alone. Some people will remember another tetracyclic that's gone by the wayside now called meancerin. Turns out that mirtazapine and meancerin are very similar chemically. But mirtazapine, quite sedating from its antihistaminic activity, property that it shares with the antihistamines, obviously, but also with the tricyclics. Its proneness to weight gain is even more prominent than with the tricyclics, and getting into the problematic range that it shares with some of the second-generation antipsychotics, such as risperidone and quetiapine. So all of these drugs can have their place. I tend to agree with Bruce that sertraline is a pretty good and flexible first-line drug, but I think more important than that, particularly in long-term patients, is if they've had a good response and a tolerable response to an agent in the past, there's usually a pretty good reason to consider it again as a first choice. It's really when they're having trouble with either the response or the tolerability that one is going to start looking for alternatives. So I'd tend to stick with the tried and true, because there are curious individual differences in what people will respond to and tolerate. And our best teachers are, of course, our patients.
So how long at the first dose, David? When should we either be going up a dose or switching to another drug?
I think this is very much a pragmatic decision. Usually if people say, oh, well, it might take 4 to 6 or even 8 weeks for an antidepressant to work. The evidence doesn't actually say that. Really, most people will show some sort of a response within the first week or two, and if they're tolerating the agent well, then I think after a fortnight, certainly a time when a dose adjustment could be contemplated. It'll be very much guided by the patient's experience of the drug. If they're starting to get better and not in a blinding rush to recover lost function, I'd be probably a little more gentle in my dose progression. So it is very much an individualized thing, and again, I think those points of early contact during the first week or two are essential in that regard.
That's human contact, not drug contact.
Indeed.
Okay, and just going to the next slide, would you care just to make some comments about this slide here? Maximum dose, rate of escalation, common side effects, key interactions.
Sure. Well, I guess we've already touched on the fact that it's very much a pragmatic choice about which drug to pick and how quickly to advance the dose. I tend to be fairly conservative and like to watch people if the clinical urgency doesn't require otherwise. Certainly watching for side effects can be very important, and I'd come back to the fact that some of the serious ones do tend to declare themselves quite early, and I would just remind people that checking in with people within a week, no more than a week, is quite useful. So even if it's a nursing follow-up, making sure that whoever contacts the person is aware of the potential range of side effects, watches for crucial things like activation syndrome or apathy, and then might ask for any unusual or unexpected thoughts or impulses. That sort of thing, I think, covers most of the worrisome things that can declare themselves early. I'm a big fan of modest dose increases and not simply abandoning one drug for another necessarily before considering the other options. And I'm more inclined, for example, if someone is not responding to a full dose of SSRI, rather than switching drugs altogether and the delay of withdrawal and washout, I'm much more inclined these days to consider augmenting with another antidepressant, or occasionally some of the other agents listed there. Each of them has a role. I guess there's not a whole lot of evidence and science about what order to try these things in, but for example, low-dose tricyclics certainly convert a number of SSRI non-responders, and it's sometimes a very gratifying and prompt response there. Even just 25 or 50 milligrams of a tricyclic can make a lot of difference, and at those doses, the legendary tricyclic side effects are an uncommon problem. SGAs, I initially shunned that strategy, but in fact the evidence is pretty strong now for the augmenting effect of them. My pick out of that group is probably olanzapine, but then obviously there are problems with that drug, as we discussed previously, mainly in the sort of metabolic and weight gain realm. I'd probably be a little more inclined to try another antidepressant as an augmenter first. Lamotrigine is an important consideration now because it is the anticonvulsant mood stabilizer with a clear antidepressant effect of its own, and also works in effectively with other antidepressants. So in the face of, for example, SSRI non-response, particularly if there's any hint of bipolarity or activation, lamotrigine can be a very helpful addition. Regarding adding the talking therapies, well, chances are if somebody's seen Bruce, they will have already been started on a talking therapy before they even get to a medication. So I think it's probably helpful to consider having them part of the picture early on. As mentioned earlier, though, some people are just not willing to go down that road, much more willing to take a medication. Alternatively, they may be so withdrawn or distressed that they haven't been able to engage with a therapist or even with the GP at that level, in which case adding a talking therapy when their mood has improved somewhat can be a strategic decision, and you can often tell when people are ready to start doing something further for themselves.
I had a question before, David, on what reframing was, and I had a good example the other day of a young woman who had a cesarean section, and she felt very bad that she had a cesarean section. So I got her to look at what she had rather than what she didn't have, that she's got a live baby. True, she had a cesarean section, she wasn't expecting it, but that would be a classic reframe, looking at what you've got rather than what you haven't got. So that's helping the patient not just see, look on the bright side, but just look at what's happened and what perhaps didn't happen. You know, if she'd gone through with a normal birth, all sorts of terrible things may have happened, given that the decision was made because of a slow labour. So that would be a classic reframe. I could give many examples, but I think we need to keep moving. So,
Sure.
So let's. So special groups, so pregnancy, breastfeeding, postnatal depression, adults, children. We might have a special webinar on children and adolescents because I guess, David, you and I are focusing more on adults here, aren't we?
Yep, indeed. I agree that child and adolescent depression is a slightly different kettle of fish. And certainly considered to be a specialist area in terms of prescribing, where the restrictions on the range of drugs that we have for adults is very much more limited.
Pregnancy and breastfeeding, any thoughts on that? That's one situation where paroxetine is not a good idea, but sertraline, I think, was the one in the BMJ review suggesting that it was least likely to be transmitted into breast milk.
Yes, that's right. And for women who are particularly motivated, you can time the doses to minimize the appearance of the drug in breast milk. I personally don't think it's necessarily worth that effort because the penetration into milk is pretty minor, and compared to exposure of the fetus during pregnancy, the suckling infant is getting a much lower per kilogram dose. So I think seriously depressed women who wish to breastfeed should be generally supported in doing that, and sertraline, as you say, is a good option.
Postnatal depression, any particular issues there?
Well, overlaps obviously with the breastfeeding thing. I guess the important thing to recognize here is that postnatal depression is very common, and indeed overlaps with the baby blues, which are even more common. One needs to watch out for the fact that a postpartum psychosis is a much more serious and thankfully much rarer presentation that can be life-threatening for both mother and infant. So certainly a degree of vigilance around at-risk women is appropriate, and certainly women with a past history of postpartum mood or psychotic problems deserve extra vigilance in that regard. I'd say probably parturition is the single highest risk period for emotional disturbance or psychiatric disturbance generally in a woman's life, related, perhaps to the hugely changed circumstances that she faces, but also to the massive biological change that her body, and particularly her brain, must adjust to with what amounts to a profound estrogen withdrawal that happens at parturition. So really, it's a high risk time, and vulnerable women in that regard do, I think, merit a special degree of oversight and support during that time. Some places, including, I'm happy to say, Hamilton now have a dedicated perinatal psychiatry service, and engaging that service in advance of childbirth is quite a good idea. They're usually pretty switched on, but I appreciate that many practitioners won't have that service handy. It does nonetheless, merit a careful degree of oversight and liaison with whatever mental health service is available in the region.
And could I add just the importance of checking out depression in all postnatal patients with the Edinburgh postnatal questionnaire, and if you haven't got one, just a simple old PHQ-9, just how important it is to pick that up because of the consequences for the mum and the child. So as you say, David, it's a very high risk time. Just moving on to older adults there. Now, there is some issue about bleeding on SSRIs and taking non-steroidals and older age. Would you care to comment on that?
Yeah, well, I mean, it's seen as a relatively more prevalent problem in that age group. I think it's the SSRI effect, as I understand it, is related to a direct action of the drug on platelets, because platelets happen to have a serotonin pump on them, and so the drug will bind to that as it does to the reuptake targets inside the brain. So why this doesn't produce more difficulty in younger people is obscure to me. Perhaps some of the audience will have an explanation for that, but it tends to be more of a complaint of older adults who are prone to get ecchymoses and things when they're prescribed serotonergic antidepressants. Was there another part to that question?
No, I guess maybe doses, lower doses in older people initially. Do you have a view on that?
Yeah, I think, yeah, initially that's right, but often older people will require a full dose, and late life depression is, of course, a serious problem for many, and the relative indications for ECT become stronger in that age group. So I think we find both a syndromal difference of perhaps more biological depressions, as well as a reduced tolerance of medication and side effects, so that the indications for ECT for both those reasons become a bit more evident.
Okay, I think we'll just move on there, and we'll do case 3, because we're going to have on the website a tapering advice sheet, which has been given to us from Professor Tony Kendrick in Southampton. It's a work in progress, but it'll be up on the website when the webinar is posted, and it helps you taper antidepressant medication depending on what the experience, because often patients will have tried to stop the medication. They'll get a withdrawal syndrome or even a full serotonin syndrome. So this is a man 42-year-old businessman, 2 years ago had marital issues now resolved, taking paroxetine 40 milligrams. He tried to stop taking it and he got shakes and zaps. You advised him to restart. So how do we go about tapering him, David?
Yeah, well, I think this is a common enough scenario, Bruce, that I'm very glad you added it into the list. Somebody who's been on paroxetine, really at any dose, but more prominently at higher doses of say 40 milligrams, is going to run into some difficulty if they stop abruptly. Now, I'm gathering that in this case, the chap decided to discontinue without reviewing his plan with the doctor, and just reported that, hey, I'm getting these weird symptoms. And in this case, they would be quite common for many individuals who had 2-year exposure to 40 milligrams and stopped suddenly. It would be uncommon to have a smooth sailing with that plan. So the first thing that can be done, you confirm that it is a withdrawal syndrome rather than a recurrence of depression. In this case, there's some very distinct symptoms of SSRI withdrawal that really don't look anything like depression. So I think you've got your pathophysiological understanding of indeed what's causing the problem, and the fact that they're rapidly suppressed when he resumes taking paroxetine pretty well clinches that story. One possibility would be, if he's lucky, he might be able to cut down by 10 milligrams a week and just ease himself off with little or no bother. Unfortunately, it's not always so easy, and some people will require transitioning onto a longer half-life drug. In this case, the usual one is fluoxetine, which has a half-life of a full week, and its metabolite even longer. So once, and fluoxetine is perfectly able to suppress the withdrawal syndrome that paroxetine leaves behind when it gets so quickly washed out of the body. So that would probably be the next step. If he can't manage a phased reduction of paroxetine, then replacing it with fluoxetine and tapering from there is a lot easier, just because of the longer half-life. The other thing to watch for in this case is that, in addition to those physical symptoms, some people get a degree of emotional lability as well. Again, different from the usual depressive recurrence. It's more like sudden changes in mood, often with a lot of irritability and just general dysphoria. So it's a pretty unpleasant situation, but it's worth checking with people what else is going on for them, because suicidal impulses are not uncommon in that setting. And I think the reasons for careful withdrawal management of paroxetine and venlafaxine are evident enough. They really are a bit of a nuisance in that regard, and probably another reason, coming back to our earlier preferences, that neither of those would be a first-line choice for either Bruce or I. Anything further, Bruce?
We're coming down to the longer-acting ones, the sertraline, the escitalopram, the citalopram, and perhaps paroxetine. I note that paroxetine is still on the Auckland pathways. I've actually sent a message to them suggesting that it be removed, so hopefully that may be removed in the future. What we're going to do now is just go through and answer the questions. We've committed to trying to answer all the questions tonight. If you're running out of steam, feel free to leave, and you can always come back to this. This will all be recorded. But our first question is, Seroquel is increasingly prescribed in secondary care. Is this something which GPs should be comfortable initiating in secondary care for anxiety or insomnia?
By Seroquel, I imagine we're referring here to quetiapine.
Quetiapine, yeah. The use of it going rocketing up in New Zealand.
And indeed, that was covered in the webinar we did last month on the antipsychotics in primary care. I'm not sure whether we'll have time to cover all of the relevant detail there, but I think quetiapine is certainly a very useful drug, but it's probably, to my reckoning, overprescribed in both secondary and primary care. And of course, much of the primary care prescribing is just following on from prescriptions that were initiated in the specialist service. So psychiatrists bear a fair bit of responsibility for that issue. Having said that, I think quetiapine does have its place, but the reasons for its use, I think, need to be more carefully considered. It certainly isn't indicated as a first-line management of either anxiety or insomnia, and yet it is often used in those settings, and also for undifferentiated distress that people can present with. Interesting to note that quetiapine, almost unique among the antipsychotics, is abusable and has a street value. Really an extraordinary thing for that class of drugs, but it is sufficiently different from the others to really merit a special degree of scrutiny. And I think the ease at which it's prescribed needs to be viewed with a bit of healthy skepticism.
Okay. Next question is just, and I think we've answered this, the advantage of prescribing escitalopram over citalopram. Basically, escitalopram has got fewer QT problems. Is there any other advantage of escitalopram over citalopram, David?
Yeah, not that I'm aware of. I think that pretty much boils down to it. They are equally toxic on cardiac conduction, but escitalopram is twice as potent milligram for milligram in terms of antidepressant and anti-anxiety effects. So on balance, escitalopram would be a preferable drug for anyone for whom there are those cardiac concerns.
I got a question about using the term stuck as a diagnostic term. It comes out of acceptance and commitment therapy. There's a podcast on our website about acceptance and commitment therapy, and there's an e-learning course there if you're interested. But I use it as a transdiagnostic term to get away from the label depression and anxiety, because for most of the patients I see, I can't quite frankly tell the difference. They all have a few points on the PHQ-9, a few points on the GAD-7, and unless they're not eating, washing, coming out of their room, then I find it very hard to tell the difference. We had a question there about, it was mentioned that first line of treatment would not be antidepressant. Is that the same case with those who are suicidal as well? Well, I think we've sort of covered that, just that. Well, do you want to make a comment about that, David, about the context of suicidality?
Yeah, I think suicidality being, of course, a very important clinical feature in the assessment of anyone with depression, or indeed presenting with psychological distress, and how that's managed will depend entirely on the context, including the past history. So it may in some ways be a pointer to severity and the need to consider medication sooner. It can likewise be a caution to delay that decision, particularly if the medicine might be used as an instrument of self-harm. It's interesting in that regard that, you know, the older drugs, the tricyclics and the MAOIs, and some of the newer ones like venlafaxine are pretty toxic in overdose, whereas the SSRIs are not. You'd have a really hard time killing yourself with an ordinary SSRI. You'd be pretty uncomfortable, but you wouldn't die just from that. But interestingly, the actual suicide rates between those different prescribed drugs doesn't seem to vary. So what it boils down to is if people are going to suicide, they might use a tricyclic, but if they're on an SSRI, they'll use something else. They're not stupid, these people, most of them, and will resort to, you know, what, if they really mean business, they'll quite likely do it regardless. So ascertaining the intent and planning is a very important part of assessment, and obviously involving specialist mental health services at that stage, and perhaps the Mental Health Act would be worth factoring in.
Question here, PHQ-9 above 12 doesn't mean the patient's definitely depressed. No, it doesn't. It just means they're distressed, and I see plenty of patients with PHQ-9 scores 12 and 14, and often they'll often be more anxious. They'll have very much higher GAD scores, but it's really, I think, better to look at it as a measure of distress, which is what we showed on that earlier table, that very high PHQ-9s don't necessarily mean you have a depression, but you're more likely to have one. Question about what's CBT? CBT is cognitive behavioral therapy. We see patients that they say psychotherapy has not helped them. How do you deal with this? Well, I would then say find out what they've done. Maybe they're asking for medication, in which case that may be a more rational thing for them to do. Got a very long question here, but I'll bypass that and come back. PMS and premature ejaculation use would be helpful. Are we able to talk about these plays, how to use and what drug? There is an SSRI that's available that's not funded, that's used for premature ejaculation. My understanding is all the SSRIs have that as a side effect. It's just a matter of timing and dose, I think. I don't know, do you have any thoughts on that, David?
Yeah, I'm bemused the fact that there's one that's specifically marketed for that, because that's a very much a pharmacological property of SSRIs. They will delay orgasm in both men and women, often to an unhelpful extent. So I guess, you know, the timing and dosing is how you do it, and so that would be very much a pragmatic negotiation between prescriber and patient, if indeed delay was seen as desirable.
Good marketing on the company that's got the product out, eh?
Absolutely.
But here's a question, but you will only receive a placebo effect if you're actually taking a tablet. Can the same placebo benefit be obtained without the patient thinking they are taking something? Don't know how to answer that. I guess that's treatment as usual. Or...
Yeah, I mean, I think that there's also non-specific benefits that patients derive just from contact with the clinic or talking with the doctor. And I wouldn't necessarily call that placebo, but I would call it non-specific. So these are somewhat fuzzy concepts that overlap to a fair extent. I think the placebo is more specifically intended to refer to the effects of medication, but I'm sure that the non-specific benefit one gets from social contact with a caring professional is as important, regardless of, you know, whether you give it that label or not. The important thing is that the placebo response and the non-specific benefits of such contact both fall away sharply with severity of depression, as that slide from Kirsch you showed, Bruce. So yeah, that's the important thing to recognize, that these these maneuvers are mainly useful in common disorders and often much less helpful and certainly not enough in the more severe end.
Question: if patients are still depressed on meds, do we stop them? We've got tons of patients in our clinic who are still depressed and on antidepressants, and every clinic I've ever been in, people just seem to languish on their antidepressants. I have to say, when you ask them about that, people are very reluctant to stop, in spite of the fact that they're not feeling any better. I mean, I find it slightly bizarre. If that was me, I would be stopping them immediately. But do you have a view on that, David?
Yeah, it is, as you say, a very common and odd sort of thing. But a lot of people are unsure whether they might have benefited and unsure how much they might have benefited, and equally worried that if they stop it, they might get worse. And sometimes, having experienced those withdrawal effects that we described earlier, will reinforce that view that, oh, they better not stop because things might become, much worse. So I think deprescribing antidepressants is an important and useful clinical task, but it's not always easy because people's mindsets often keep them attached to a medicine even when it's ineffective.
Exactly. I think there's some figures from overseas. Just a minority of patients actually want to stop them once they've been on them for a period of time. Question here: how do you make a decision between prescribing one SSRI over another, fluoxetine over sertraline? Well, I guess I've got to the point where the dosing on fluoxetine is a bit dicey, the issue of whether 20 milligrams is a reasonable dose, and sertraline just seems to be simpler to use, doesn't have cardiac problems. If your patient gets pregnant, there's less of an issue. You can use it with breastfeeding. So that's, and the evidence is that drugs like escitalopram and sertraline have the best benefit to side effect ratio. So that's why I pick sertraline myself. But do you have a view on that, David? How do you decide?
Yeah, no, I think as a general principle that all makes sense, but I think what would trump that argument is somebody, for example, who's had a good experience in the past and is now experiencing another episode, and I'd be inclined to just stick with what they know and expect will work, because it most often does. So your preferences for the reasons for preferring sertraline and escitalopram are perfectly valid, but I think the patient's preference probably gets the casting vote on that for me.
Yep, I would go on with that. What's the best antidepressant to use in a patient with hyponatremia, given that SSRIs can cause hyponatremia?
Yeah, I believe that has been studied in the elderly, and my understanding is that the tricyclics have less of that liability, particularly the ones that aren't as active on the serotonergic system. So that would be an option. I guess also one might be relatively more inclined to try low-dose mirtazapine in somebody like that. So yeah, just a range of options there. It may also be, as with any difficulty in tolerating a physical side effect, it may be a reason to emphasize talking or other behavioral therapies if appropriate, just because severe hyponatremia is a real pain. You get a real encephalopathy at risk there, so it needs to be taken seriously.
Yep. Just going back to the diagnosis of stuck, the other thing I find with patients, when I say that to them, virtually all of them prefer the diagnosis to depression or anxiety, and it describes how they feel. They feel stuck. Enough of that. Okay. Yeah. When anxiety, depression is a mix, would you recommend, and anxiety and activation become an issue, would you recommend a benzodiazepine in the short term?
Oh, that's a tricky one. I'm normally a benzo antagonist, as you know, Bruce. In fact, my nickname used to be Flumezanil, but I think benzos do have a role to play, and there is evidence that if carefully managed, initial treatment with a benzo, carefully monitored. When an SSRI is initiated, can be helpful because it takes the edge off of the activation, may help with any SSRI-associated insomnia, for example. The problem is being quite judicious about both the monitoring, the dosing, and the duration of the prescription. So ideally, it wouldn't go on any longer than a fortnight. And if one is getting pressure to extend it longer, I think the treatment package needs to be reconsidered. The other thing about benzos, of course, is that in addition to those longer-term risks, they are also disinhibiting drugs. And so anyone with a history of impulsive behavior or violence should probably only get benzos under pretty tight supervision.
There was a Cochrane review on it, and the numbers need to treat about 6 to get an additional person better. So they are effective, but I think what you say, David, you know, we've all had the problems of not being able to get somebody to stop a benzo. So how many psychology sessions should a patient need before commencing an antidepressant? Pick a number, David.
Well, I think you were just saying before, Bruce, about how long that piece of string was.
Yeah, it's hard to know, isn't it? To me, it just seems like how is the patient? I would renegotiate with the patient. I'd say, I'm not anti-medication. I would just say medication's an option, and we need to discuss that at some point if you're not getting better with psychological therapy, or maybe you need to see somebody else. You know, it's all about, I mean, primary care is all about negotiation rather than rules, I think, would be my thing. And I don't think there's any rule around that.
Yeah, indeed. I agree with that. And then it may also depend on what other treatments are available. I mean, one thing that many GPs find is that the availability of counseling supplied through the PHO is terrific and effective for many, but there will be a subgroup that need more and might need something really more at the sort of specialist end of, for example, CBT. And in that case, how to access the relevant professional, usually a psychologist, will depend region to region, and there may be some co-payment required. So all of that is going to vary depending on where you are, but it's an important step, and certainly I think the GP is in an ideal position to be a gatekeeper there and make that onward referral if it's very clear that there's a behavioral problem or somebody is specifically motivated for CBT. It's quite an effective treatment paradigm, but it does require a degree of commitment and psychological mindedness on the part of the patient. So this will be probably for the 10 or 15% who don't respond to the usual things on offer in primary care.
So here's a question on the management of women with postnatal depression. So if we could park the breastfeeding part of it, do we treat the woman with postnatal depression any differently from a woman or man without postnatal who is equally depressed?
Yeah, I think we do, in the sense that we take into account the phenomenal extra stresses on the woman. I mean, apart from anything else, sleep disruption is usually a major player in that. And so the social supports of how to, make sure that the burden on the new mother is minimized can be very important. So that will often involve family, but it might involve mental health services or other helpful agencies that can support women at that stage. So I think the need for psychosocial inputs is often relatively greater at that point, just because of the circadian disruption and the huge sort of readjustment demand that is falling on those women.
Got a question here about neurolinguistic programming, which I can perhaps answer. We've done a randomized trial on a rapid phobia cure, so it works for phobias. We're just doing a randomized trial at the moment on a rapid anxiety treatment, which makes people feel better in about a minute, which I won't describe here. We have done a small trial on depression, and it didn't work in the first 30 people, and we abandoned the study. This is one of the ones that isn't published, of course. I think when people get depression as such, they get more shut down. It's a bit more difficult to get the network functioning again. Okay, so we're not going to comment about young people. So I got a question here about fluoxetine has been shown to increase suicide in depressed adolescents by 3-fold when comparing depressed adolescents taking fluoxetine versus those not taking antidepressants. Do you think this may be due to an increase in sympathetic tone by antidepressant that has been shown by the heart rate variability studies? I suspect the increase in sympathetic tone with antidepressants reduces their efficacy, especially after the 6 months of treatment.
Interesting question. Certainly that increase in sympathetic tone is not an intrinsic feature of the SSRI. I think that is an indirect, fairly common idiosyncratic reaction. Idiosyncratic, it depends very much on the patient. So some patients find SSRIs to be serenic. They get chilled out, mellow, cruisy with SSRIs. Other people get just the opposite. They get ramped up, tense, agitated, maybe even akaphisic. So really quite dramatic individual differences there. And obviously it's the latter group that will be showing increased sympathetic drive. And I think as the questioner implies, that's the group that are also apparently at increased risk of suicidality. So if one sees that syndrome, regardless of, whether it's associated with increased sympathetic drive or not, I think it is a situation that merits careful reevaluation of the treatment package, because this is getting close to tiger country, and we certainly appreciate now that that reaction needs to be managed to minimize the risk.
Interesting comment on heart rate variability. I've got a little app on my phone, and I stick a little probe onto patients' ears, and if they do a mindfulness exercise, they can reduce their they can improve their heart rate variability. A bit like a heart rate variability is a bit like a fetal heart tracing, and it's the one objective measure of sympathetic tone. So it may be something that people want to play with. The probe costs about $150, and the app is free, so you can actually have people doing mindful things in your office. Okay, so we've some of these questions. In the real world, do you find 15 minutes is enough for this type of consult? I think you have to be willing to get people back. It's very hard to add this sort of stuff on. If I'm seeing somebody for a mental health problem, I often book a half-hour appointment to make sure that I'm not pressured into time, because patients arrive late. I've got a waiting room full of patients. And fortunately in Counties Manukau, we get the extra payment, and that makes that possible. And I think if you're not getting it in your PHO or DHB, you probably need to start stamping your feet, because otherwise general practice is paying for mental health services. So venlafaxine, do we need to do an ECG before pre-commencing? I mean, where do we get to with that, David? I mean, at low doses, do we need to do ECGs on anybody if they've got no other reason, if there's no QT problem in the family?
No, I would say not.
Yeah. Risk of QT when combining escitalopram with sildenafil for erectile dysfunction. I don't know that. Do you know the answer to that?
I don't. Sorry, I would need to look that one up. But it's a yeah, it's a common enough combination given the side effects of SSRIs that I think probably something that we should look into and perhaps comment on later.
Got a nice question here from a clinical pharmacist friend of mine. QT prolongation is also relevant when person is taking other drugs that prolong QT interval. So that's probably the more situation where you want to be where you want to be careful. Do we need to do ECGs prior to TCAs in the elderly, tricyclics?
In those with a cardiac history, I would say yes. In those for whom TCAs are a sole antidepressant agent, and thus the dose is expected to go, to 100 milligrams or above, I think that would be prudent, just because of the increasing risks with age. At low dose TCAs, when they're just being used as augmenters, or for example for sleep or for neuropathic pain, I would say probably not.
We're going to have those of you who are interested in who are getting QT anxiety here. Chris Ellis is going to be running 2 clinics at the symposium next year, so be interesting to see what the uptake of that is, because I think we will have created a bit of anxiety tonight. What is your advice for dosing citalopram on a patient who is on amitriptyline for chronic pain? Does the amitriptyline need to be reduced or stopped? I think this is your pet area, David.
Yeah, well, normally we go the other way. We have somebody on an SSRI and we add in a tricyclic. Here we've got someone who's on amitriptyline for a pain complaint, and I'm presuming that's going to be at a lowish dose, probably not more than 50, maybe only 25 milligrams. In which case, I would assess the current efficacy and tolerance of the amitriptyline before making that call. But it may be, in this case, if one's adding an SSRI, was it proposed to be sertraline, Bruce, or another one?
No, citalopram.
Citalopram. Yep. Well, look, I think the chances of a kinetic interaction are acceptably low. Pharmacodynamic interaction is possible with the unlikely but still possible occurrence of a serotonin syndrome. I think I would tend to preserve the amitriptyline at the tolerable dose and add in a low dose citalopram initially, perhaps 10 of citalopram or 5 of S-citalopram, and just monitor. My sense is that one shouldn't necessarily modify the pre-existing antidepressant in order to make room for the next one along. It depends a little bit on the relative importance to the patient of the pain complaint versus the mood disorder.
Could you consider using nortriptyline and look at blood levels if you're worried about the interactions?
Oh, you could, but again, I don't think nortriptyline levels are particularly valuable unless one has concerns about either non-compliance at one end or real toxicity at the other. In the normal clinical range of things, I don't believe that levels are that instructive. I say the same thing about clozapine levels, the same thing about valproate levels. I think they are rather less helpful than some would claim. And I think what one is really obliged to do is careful clinical assessment and adjusting doses from there. So very much treating the patient rather than the numbers, with the proviso that if there is serious concern about non-compliance or toxicity, that then of course a level can be helpful.
I'm going to now restrict you to one sentence answers, David, so that we can all get to bed tonight. So meclobemide, it's popular in this listener's area. Your thoughts?
Meclobemide has its place. It's not a first-line drug for a variety of reasons. Its efficacy certainly less than the older MAOIs, but it is also more tolerable. So I would see it as a second, possibly third-line agent, but still has its usefulness.
Cool. Pharmacist here saying a patient phoned up on 200 milligrams of sertraline, was feeling lousy, showed muscle weakness and fatigue. She suspected a serotonin syndrome, but presumably serotonin syndromes occur when you're stopping something rather than on something.
Oh no, I think probably those are two different things that have overlapping clinical features. A serotonin syndrome is a serotonergic excess that you might see, for example, with high doses of an SSRI or combination of various serotonergic drugs. A surefire way to see it would be to combine an SSRI and a monoamine oxidase inhibitor, and there one sees flushing, autonomic instability, piloerection, all the activation symptoms of the serotonin. The withdrawal syndrome can look a bit like that in terms of some of the complaints, but I think the physiology is quite different, and so the complaint of the woman on sertraline, I don't think would if it's a stable dose of 200, would be unlikely related to withdrawal. Could be related to a serotonin syndrome, but it doesn't sound like it, because I didn't get the sense that there's that autonomic flavor to it.
Okay. A word on transcranial magnetic stimulation.
A promising modality that is only starting to become available in New Zealand. I think there's a private clinic in the North Shore and a research machine in Auckland Central. I'm not aware of other machines in the country. It would seem to have a future, but its efficacy certainly less than ECT, but its acceptability to patients and its side effect profile better than ECT. So it will have a place, and we look forward to it being more widely available.
Question here about libido. My understanding is the best drug for not reducing libido and possibly increasing is bupropion. Would that be your view?
Yeah, I think that's right. That can be positively beneficial, as it's a dopamine agonist, much in the way we sometimes see with Parkinson patients and L-DOPA. They recover quite well, lost function. Mirtazopine's not bad either, certainly very different from the SSRIs in that regard. And another drug that we'd like to have in New Zealand and don't yet, called trazodone, which some of you may have used overseas, is very helpful in that regard.
Question here about safest SSRI in pregnancy. If you go back to my GEM, I think 2015, there's one there on SSRIs in pregnancy, and it's got actual link to the review. And again, sertraline seemed to be the one. Paroxetine has a neonatal problem, so that's definitely one not to use. But I think probably my view would be you probably want to get some advice from a psychiatrist if you're going to put somebody on an antidepressant in pregnancy, just with all the possible harms, and that's pretty uncertain at the moment. And I think it would be, you'd want to share that responsibility. I don't know what your view would be, David.
Yeah, I think that's reasonable. Certainly all available psychosocial maneuvers should be considered before taking that step. SSRIs are, with the exception of paroxetine, are relatively okay. I think they're category C. Paroxetine is a B, which means just don't go there.
A patient on long-term paroxetine falls pregnant. Would you suggest switching SSRI? I think they mentioned that in that that BMJ article, but I think they thought if it was effective, then probably not. But it's a very tricky situation.
Yeah. I think the paroxetine risk in pregnancy is related to cardiac malformations, and it's a relatively low risk, but it is definably different than for the other SSRIs. So I would be inclined to reduce paroxetine and perhaps transition to an alternate drug.
Listener here saying that Mood Gym's no longer free. That's terrible. So thank you for that, because I've been recommending it. She recommends SAM app, Headspace, or the Calm website, calm.auckland.ac.nz, put together by Tony Fernando and Fiona Moyer. Excellent website with lots of MP3s. PHQ9 or Kesletin, which one's better for screening? I don't think anyone's particularly better for screening. Better to get familiar with one, I think, would be my view. So a couple of thank yous for the webinar, and I think that's sort of the end of the main questions, David. So I think we will probably call it a day at this point. But thank you very much for your expertise, your pharmacological expertise, and helping us with this webinar tonight. I think the questions have flown thick and fast, and we still have a reasonable audience online. So thank you to those of you. So in future, we're going to try and answer the questions while we've got the speaker fresh. So just like to thank Pharmac for supporting this webinar. They don't control the content. That's done by the Goodfellow Unit. And thank David, and thank all you audience for participating and asking questions and making it into a really interesting show.